All right. All right, so the title of my talk is The Bee's Nest, Clinical Case and Review of VHL. So I'll start with the case and kind of go through things a bit leading up to Dr. Oliver. My patient is a 25-year-old healthy male who presented with painless progressive vision loss in the right eye over the course of 5 months. He had progressive field loss centrally and nasally. Oh, that would probably help. Let's see. Oh, no, thank you. All right. So the patient had progressive field loss centrally and nasally. Photopsia is in a purple shade coming across his visual field. He denied trauma or prior eye surgery. He had no known past medical or surgical history, only mild myopia for ocular history. He was adopted, so he had an unknown family history. For his ocular vitals, he was 2400 in the right eye with an RAPD in the right eye. You can see his visual field defect below there. He had a fairly normal slit lamp examination. And this is what his right eye looked like. I was hoping one of the residents might be able to describe this photo. Any brave takers?
Whoever the brave taker is, could you talk into the mic?
Apparently you are the brave taker itself.
You guys hear me okay? Yeah. So it's a fundus photo of the right eye, and you can see kind of really markedly a mass with some leakage. It seems like a vascular mass with some feeder vessels superiorly and a lot of like exudates throughout around that superior like area. Pretty large mass, and I think maybe inferiorly you can also see some elevation with some exudates as well. Maybe kind of nasally as well, but I cannot reach that. Some whitening of the retina there.
Great. Just kind of a zoomed in view of that kind of conglomerate of retinal vascular lesions. You can see those feeder vessels, and like you said, an exudate of retinal detachment at the kind of inferior base. You can see all those exudates kind of accumulating there. The fellow eye was unremarkable. Here we have an OCT through kind of going superior to inferior. Any thoughts on this, Itzo?
Either. You can see some subretinal fluid and pretty much some distortion of the retinal layers, kind of incomplete thickness, showing maybe some chronicity and some exudates also in the outer retina, kind of showing the same.
Great. You can see also left eye, unremarkable. So here's an FA early phase.
Again, if it's early phase, kind of some early feeling, I guess, and some hyperfluorescence around the area, and of course, that's a lot of like hypofluorescence as well around those areas, maybe showing some blocking, but it's kind of early there.
Yeah, so arterial phase, you can see these are some of the feeder vessels here with the arrows. And then you've done a lot at some, I'll take it from here. And here's the sort of the venous feeder vessels as well. Late phase, you can just see the leakage from these vascular lesions, and there's kind of innumerable vascular lesions there. And not really much going on in this left eye still. So it's pretty clear what the diagnosis is, but for the residents and everyone, we'll just go through a differential diagnosis. Differential diagnosis includes retinal capillary hemangioblastomas, Coates disease, retinal cavernous hemangiomas, racemose angiomas, or Wyburn-Mason syndrome, VPTs, and Becker. These are all just vascular lesions that if you haven't seen a lot of, might be tough to differentiate. So briefly, retinal capillary hemangioblastomas are spherical orange-red vascular tumors with dilated and tortuous arterial and venous feeder vessels. They can occur as isolated lesions, though most commonly they're associated with VHL. And multiple retinal capillary hemangioblastomas alone are diagnostic of VHL. Coates disease, this presents in the first or second decade of life. It's unilateral typically in 85% males. often presents as leukocoria, and you have to differentiate it from retinoblastoma. Or severe exudation and telangiectasias are the key finding. Treatment for coats is typically laser to abnormal vessels. Cryo and or vitrectomy may be considered for extensive fluid or unresponsive patients. Retinal cavernous hemangioma are grape-like clusters of thin-walled saccular angiomatous lesions of the inner retina or the optic nerve head. They're slow to fill in FA, no dilated feeder vessels like in our patient. They're not associated with exudates, subretinal fluid, but they can rarely cause vitreous hemorrhage. You can laser or cryo them if they're bleeding, otherwise you can just monitor them. Racemose angioma, along with Wyburn-Mason syndrome. These are congenital retinal AVMs associated with ipsilateral AVMs of the brain, face, orbit, or mandible. They have dilated ectatic vessels without an intervening capillary bed and no large sort of vascular tumor like in our case. Not typically associated with exudation or leakage, though rarely they can be associated with vitreous hemorrhage, RVO, or NVG. There's a risk of hemorrhage after dental procedures due to interosseous AVMs of the maxilla and mandible. So it's important to identify these, image these patients, and caution them if they're going any intervention. VPTs, typically present in the third or fourth decade of life, typically infratemporal. The peripheral globular yellow-pink vascular masses with subretinal exudation. The vessels leading to the VPTs are less dilated and tortuous than retinal capillary hemangioblastomas. They can be primary VPTs in 74% or secondary to other ocular conditions such as uveitis in a fraction of patients. So back to our differential diagnosis, these are pretty clearly retinal capillary hemangioblastomas associated with von Hippel-Lindau. So von Hippel-Lindau is a hereditary multisystem progressive cancer syndrome. Prevalence is 1 in 36,000. Mean age of diagnosis is 26, recall our patient is 25. It's autosomal dominant with a 90% penetrance, and it's caused by mutations in the VHL gene on chromosome 3. 20% of cases are de novo. If you recall, our patient was adopted, so we're not sure if he had a family history or not. A little background history on von Hippel-Lindau. These lesions were first described in 1904 as angiomatosis retinae by Eugene von Hippel. Later in 1926, Arvid Lindau established the association between angiomatosis retinae and cerebellar cysts and other systemic tumors. And the syndrome was first coined in 1936 as von Hippel-Lindau. Early case reports described these retinal lesions as the bee's nest, hence the title of my talk. And I didn't really get it at first, but then I kind of played around with it, and I guess I could kind of see it. So, and if you want my consulting services for my graphic design, I am available. So the VHL is a tumor suppressor gene located on chromosome 3. Patients have one germline VHL mutation, and tumors only develop when a second somatic mutation occurs. It plays an important role in initiating ubiquitin-mediated degradation of HIF-1 alpha under normoxic conditions. Loss of this normal VHL gene leads to accumulation of HIF-1 alpha, which can lead to activation of hypoxia-inducible genes such as VEGF, PDGF, and EPO. An increase in these factors leads to uncontrolled angiogenesis and hypervascular tumors. And pathologic VHL gene can also lead to abnormal gene regulation of p53 and other oncogenes, which can play a role in tumorigenesis. VHL gene also has a role in microtubule stability and cilia maintenance, which may explain the pathogenesis of VHL-associated cysts. So this is just kind of showing how VHL works under normal conditions. So you have HIF-1 alpha there bound and targeted for ubiquitin-mediated degradation by the VHL complex. That's what happens under normoxic conditions in a normal patient. Under hypoxic conditions, HIF-1 alpha is upregulated and ends up leading to these downstream production of VEGF, PDGF, and EPO. And that's basically what happens in the pathologic state of von Hippel-Lindau, where you don't have a functioning VHL complex. So HIF-1 alpha is upregulated, and you lead to lots of these production of these vascular factors. The diagnostic criteria for von Hippel-Lindau. So if patients have a family history of VHL, they can have just one of the following: one CNS or retinal hemangioblastoma, pheochromocytoma, or renal cell carcinoma, and that is diagnostic of VHL. If there's no family history, then they need at least 2 CNS or retinal hemangioblastomas, or 2 visceral tumors, or 1 CNS or retinal hemangioblastoma and 1 visceral tumor. Gold standard is really confirming diagnosis with genetic testing, but in most patients, you can have a pretty good idea that this is von Hippel-Lindau if they have these criteria. There's a lot of systemic surveillance for these patients for multi-system tumors. So for the retinal hemangioblastomas, they should be screened at birth if they have, positive family history or they have known diagnosis, and yearly thereafter. For pheochromocytomas, they start screening with 24-hour urine fraction and metanephrines at age 2 and then annually thereafter. For endolymphatic sac tumors, they get audiograms starting at age 5 and then every other year. For the CNS hemangioblastomas, they get MRIs of the brain and spine starting at age 8 and then every couple of years. And then for renal cell carcinoma and pancreatic neuroendocrine tumors, they get MRIs of the abdomen starting at age 10 and then annually thereafter. So lots of imaging for these patients. As for the ocular complications of VHL, really they have to do with the retinal capillary hemangioblastomas. They can lead to CME, exudative RDs, TRDs, vitreous and subretinal hemorrhages, NVG. Optic nerve hemangioblastomas can occur as well, a little more rare. And you can have a nystagmus from cerebellar hemangioblastomas. So retinal capillary hemangioblastomas are hamartomatous vascular lesions with dilated tortuous arterial and venous feeder vessels, as I mentioned before. They're often the earliest and most frequent finding of VHL, occurring in about half of patients. The mean age diagnosis of these is age 25, just like our patient. 50 to 60% have bilateral lesions and are often asymmetric. And in patients with solitary retinal capillary hemangioblastomas, earlier age at presentation makes VHL more likely than a non-VHL retinal capillary hemangioblastoma. So in this photo here, you might not really notice much, but actually there is a very early retinal capillary hemangioblastoma. Some of these are difficult to detect if you don't do an FA even. So you want to catch them here and treat them here and not when they get like this. It's a lot harder to manage, as you can imagine. And the management is really aimed at tumor ablation, which in turn reduces exudation. There's lots of different options. I'll go through a few of them and sort of the evidence for those right now. So laser photocoagulation, Kovacic et al. Reported 304 capillary hemangioblastomas in 74 patients treated with laser. The median size was a quarter disc diameter, which seems small compared to the patient that we had. They used green laser with long duration burns, 0.1 to 0.7 seconds. That's really long duration. And 97% of the lesions were inactivated with laser alone, with a mean of 1.6 sessions. The range was 1 to 8. Not surprisingly, larger hemangioblastomas required more sessions. 7 eyes required cryo after laser partially inactivated the lesions. And laser is generally effective for smaller peripheral lesions without extensive subretinal fluid. This is just an example of pre and post there. It can result in good involution of these lesions. Cryo has less robust data. It's generally preferred for anterior lesions greater than 3 millimeters in size associated with subretinal fluid that aren't responsive to laser. Anti-VEGF, I went through the mechanism with VEGF upregulation in these patients, so it makes sense that anti-VEGF may work. There's several case series, limited effectiveness, and really they don't cause regression of the retinal capillary hemangioblastoma unless it's incredibly small. It may help more with the exudation as sort of an adjunctive treatment. And it's also an option for juxtapapillary lesions, but can't be lasered or cryoed safely. So this is a patient that had subretinal fluid from a juxtapapillary hemangioblastoma with anti-VEGF, did quite well. Vitrectomy. So Krstolik et al. Reported 24 eyes undergoing vitrectomy for hemangioblastoma with an exudative detachment. They essentially count fingers to start, or even hand motion. All the hemangioblastomas were over 2 disc diameters, and 15 out of 24 had conglomerates of several capillary hemangioblastomas, similar to our patient. All eyes achieved anatomic success with destruction of the hemangioblastomas. 4 out of 24 required an endoresection, and 20 out of 24 were just ablated during surgery with high intensity laser or cryo. In order to reattach the retinas, 14 out of 24 required a retinotomy, and visual acuity improved in most patients at 6 months. Patients who did not require retinotomy generally did better, with an outcome of 21/15 for their vision versus basically like count fingers range for patients that required a retinotomy. And then importantly, some patients did develop NVG post-op. This is definitely not my video, but a very cool video of how you would actually manage one of these with a vitrectomy potentially. For those of you who don't do vitrectomy, we don't typically use sutures inside the vitreous cavity. That was pretty baller. As for the prognosis, Toy et al. Studied visual outcomes of 249 patients that were followed for a mean of 8 years. At baseline, 47% of eyes had ocular involvement. 78% of eyes without initial involvement remained hemangioblastoma free over that 8-year period. And 30% of eyes with initial hemangioblastomas developed more hemangioblastomas in the study period, and 7% of eyes progressed to ptysis or enucleation. The mean change in visual acuity for these patients was a drop in 7 letters, with almost a quarter of patients losing more than 10 letters of vision. They found that missense or protein truncating germline mutations were associated with increased anatomic involvement and functional deterioration, which highlights the importance of genetic testing and counseling for prognostication in these patients. Systemically, it's a poor prognosis as well. Life expectancy is just 49 years. Improved survival has been shown with systemic surveillance, and renal cell carcinoma is the leading cause of death in up to 75% of patients. CNS hemangioblastomas are the second leading cause of morbidity and mortality. They're benign, but their mass effect can cause neurological compromise. Back to our case. So our patient went under systemic workup for other tumors, then an MRI brain as well as spine, which was negative for hemangioblastomas. Urine and plasma metanephrines was negative for pheochromocytoma. However, on CT, they had this nice arrow sign, which was concerning for renal cell carcinoma. Therefore, the patient was referred to urology, endocrine, and genetics. For the eye, there seemed like there was too much subretinal fluid and much too large and extensive lesions for laser to work. He was really against basically any sort of intervention. He was a pretty challenging patient to manage. We initially planned to do some injections to hopefully control some exudation and then lead to cryo. This was ineffective. We recommended cryo and vitrectomy, but the patient really declined any further treatment due to poor visual acuity. Really sadly, the patient left the state and he no-showed his follow-ups, including with urology. So I have no idea if this patient's even alive at this point. He was a patient that I called numerous times, but we've all had patients that we try to get back to the clinic, and sometimes it's challenging. In ophthalmology, usually that doesn't mean the patient may die. But unfortunately, this patient has presumably a malignancy that's being untreated. So hopefully got help elsewhere. So in summary, capillary hemangioblastomas associated with VHL. Ophthalmologists play a key role in VHL diagnosis. Multiple capillary hemangioblastomas alone is diagnostic of VHL. Patients require a lifelong multi-specialty surveillance for tumor development. Laser and cryo can be used for smaller lesions, and vitrectomy with en bloc resection should be considered for extensive exudative or tractional detachments. These are my references. So I'd like to thank you and invite Dr. Oliver to probably present some similar things, but with his expertise and knowledge. Thanks.
Hot mic, and Bill just said, I just gave Dr. Oliver's talk. No, really, it's an honor for me to introduce Dr. Oliver. For those of you who don't know him, he's the Vitaly Schlossman Chair in Retinal Diseases. Scott's been with us for well over a decade, leading the retina service and director of our eye cancer program. And really, I think about Scott as, we use the terminology, the triple threat, and I try not to use it because you don't want to use the word threat in a letter of recommendation, right? Well, like that's the only word they see, threat. But triple threat, clinical, education, and research, and he is that. But in retina, he's the triple threat in terms of his ability to handle adults and children and ocular oncology, most complex cases. So excited to hear his talk on managing retinal hemangioblastomas in von Hippel-Lindau. And having managed some of these patients over the years, less since Scott's been here, it's the social aspects of managing these patients is really difficult because they go through, these things that you just can't imagine, right? At the age of 25, they end up with one thing and then the next thing and the next thing, and it's just endless. But my experience is that they kind of often have a great perspective on life from the ones I've taken care of. So Scott, thanks so much for speaking to us today.
Great, I got one. Thanks, Ramesh. Good morning and welcome. This is awesome to see a full conference hall. We haven't had this in a long time. I hope all of you got a bite of breakfast. We're glad that you can make it in person, plus those who are joining us by video. And Bill, thanks for covering a lot of the basics of this disease. That was a really comprehensive overview of VHL. What I would like to do is build upon some of the intro material that you've heard to talk about how we actually manage this disease as ophthalmologists and these patients. And I love VHL for a variety of reasons, but there are several. For us as VR surgeons, they're some of the most challenging cases that we have. And we have to use our diagnostic acumen, we have to use our surgical and laser techniques to be able to try to manage these patients. And if we're careful about it, we can avoid our worst outcome as a specialty, which is blindness. But the other thing that I think is great about it, other than the fact that you also know it will be on every test that you ever take for the rest of your careers, because it's the perfect disease for writing test questions. We also have to use our MD hat. And ophthalmologists play a huge role in establishing this diagnosis and also in managing these patients over the life spectrum. And it has been really rewarding and interesting to circle back with my urology colleagues and also my neurosurgical colleagues, amongst others, as we take care of these patients and these families to try to deliver the highest quality care and keep them alive as long as possible. So we'll cover many of the things that Bill has already gone over, but mostly I'd like to get a lot of images in front of you so that you can see this disease and really see the spectrum of this disease. Often we're thinking in terms of find the hemangioblastoma and then don't miss the systemic disease. And I think that's a great starting point, but then what do you do if you find it? And if you're here, you may make a phone call, phone a friend to help manage it. Once you're out in practice, whether you're a glaucoma specialist, general ophthalmologist, or a retina specialist, the next steps can really be key. So hopefully these images and cases will help you with that. This is a young lady who I met. She had had known tumors since 2012. And she really captures sort of the classic VHL patient who comes to me. Her mom was exhausted trying to find specialists who knew something about VHL. So everybody has read about it or heard about it in med school or maybe in residency. But she had this sort of fractured patchwork of specialists that she was trying to juggle and coordinate. And she had been told, yes, you just watch these tumors. Often the tumors get picked up and they don't do much for a long time. And so people tend to sit on them. Now, when I see this picture, I think, uh-oh, and I told them this, taking care of this situation at this point now got complicated and does require a lot of VR intervention. She's got multiple tumors, as you can see. She has an exudative detachment. There's significant fibrosis, retractional detachment supranasally. And so this case is now going to be a heck of a lot more work than it has been in the past. Here you see classic feeder, drainer vessels, multifocal disease. The autofluorescence is a great way to pick up small tumors. I like to challenge myself and the fellows to try to find all of these clinically. We're spoiled by Optos and by fluorescein angiography because we can light up all of the tumors. But you actually can find very small ones, as Bill showed, and I have a couple cases there. So you need to find every tumor and identify it. I try to keep a count of the number of tumors that are present. And in her case, we took her to the OR and extracted the tumor. I do send all of these for pathology. One of the things that to me is a very interesting question is which tumors go into a very rapid growth of just the vascular lesion and which then start to fibrose. And you can see up here, we've got some bridging fibrosis. And it's really the fibrosis that ultimately leads to significant complications and the TRD. This was the reason she presented, was the subretinal fluid. But in talking to her, she didn't seem quite well. This is a teenager. Her weight had been dropping, went from 94 pounds down to 68 pounds. And in talking with her mom about that, she had been worried for a long time, but didn't quite know if it was related to, just the fact that she was a sick kid. And so maybe there was a psychological aspect. This young lady was admitted to Children's twice to the eating disorders unit before ultimately getting neuroimaging. And on neuroimaging, we see that she's got a brain lesion. And it was actually a mechanism of central anorexia. And with treatment of that tumor, she started to put weight back on again. So I won't re-review everything that Bill has already outlined for us. And I promise to not torture you with too many mechanism diagrams. But this one, to me, helps to make the most sense of how VHL impacts tumorigenesis and ultimately it's vasculogenesis that leads to these vascular tumors. So in the HIF pathway, two things are able to turn off the degradation of hypoxia-inducible factor. One of them is oxygen and the other is VHL. So we need mechanisms for responding to hypoxia, and that's the sort of native regulator. But obviously if VHL is knocked out, then ultimately you wind up with increased expression of EPO, VEGF, PDGF, and TGF. A few incidence stats for you here. This is a rare disease, but it's not exceptionally rare. As you know, it's autosomal dominant, and many times people don't find out they have it until they've had children. So most of my cases are actually part of a family cohort. And one of the critical things is finding out where is your family member getting care? I have been astounded by the number of times that a patient will say, oh yeah, dad or grandpa was known to have tumors in multiple locations, but nothing is happening. And so you do need a little more time to be able to talk through the individual case, but also make sure that the rest of their patients are plugged in. We find hemangioblastomas in a lot of patients. Now, the VHL gene is a very large gene. And so depending upon the family's mutation, you can have a wide spectrum of manifestations. There tends to be a little bit of a clustering effect. So you'll find families that have a high preponderance of renal cell or a high preponderance of eye disease. And then you'll have others who have no penetrance with the eye tumors. And so once again, the family history is helpful. Once you've identified the tumor, then you have to decide how to treat it and how to manage some of the downstream effects of that treatment. Most of what we know about VHL historically, in terms of its natural history, came to us from the NEI. And the NEI has followed a large, to my knowledge, it's the largest cohort, 220 families, 335 patients. It's given us an idea for what to expect when you take care of this disease. The majority have bilateral disease with no correlations between age, gender, and laterality for severity of the ocular lesions. You see a wide variation in terms of the number of capillary hemangiomas. And many of them are small. So often, Bill presented a stat about the fact that many of them are pretty tiny, but that's skewed by all of the small tumors. You wind up with a few very large tumors that consume most of the work in taking care of them. I'm troubled by this statistic, 13% of eyes that were enucleated or were tisical. We see bilateral blindness from VHL still. To me, it's unacceptable that 1 out of 20 patients goes blind from this disease. That to me represents a lost opportunity. And the older they are, the more advanced the lesions. Certainly if they're located near the optic nerve, the higher the chance that patient loses vision. And so detection obviously is key. So in patients who did not have retinal capillary hemangiomas, the majority of them did very well. So nearly 80% were 20/20 or better. But you can see in white over here that we've got a quarter who are bilaterally worse than 20/160, and only half who wound up 20/20. This is a patient of mine who was treated at every major eye institution on the East and the West Coast. And he was enucleated on one eye, and he arrived looking like this on his left eye. He was bare light perception. He had a juxtapapillary tumor, along with several others, multiple VR interventions. And you can see this is a very scarred and unfortunately hopeless situation. So he does still have the eye. He's bilateral NLP. And once again, this and premature death are the outcomes that we have to fight for regularly. One of the questions that will often come from either a VHL team or sometimes a primary care doc that's relevant for all of us is, how do we screen these patients? What constitutes an appropriate screening regimen? Generally speaking, it's an annual eye exam. And this really does not require advanced imaging. It requires an indirect ophthalmoscope. And so it's something that all of us can participate in and assist in. I do have a number of kids who are sent. Their parents are identified with VHL and they find the gene in the kid. Now, fortunately, small children usually are not presenting with significant tumors. We do use Optos for screening. You can see all the blink artifact. That's because this is a little one, but it's still a short acquisition time. It's a very useful adjunct, particularly for wiggly ones, in trying to pick up a tumor and at least know that it's there. And then you can put the kid to sleep if you need to. There is some debate about the use of fluorescein angiography for detection of these tumors, and whether that is something that is warranted for every patient or just those who are in a higher risk age group. I don't give fluorescein on every individual who's referred into my clinic. But once folks are into adulthood, or if we know that their family history reflects a higher risk, we will use fluorescein angiography, and you can see that you pick up a lot of the very small tumors. Here's a nice example of a tiny tumor that lights up very easily, and in fact, an even tinier one where the black arrow is present on fluorescein angiography. Some of these have been termed clinically invisible. I would argue that maybe they're not. but you just have to look very carefully to find sometimes very, very tiny tumors shown here in the left eye in this case that was just outside the fovea. So it's a nice way to calibrate your clinical exam skills. In terms of angiographic dyes, this is a retinal tumor, so we use a retinal dye, fluorescein sufficient. ICG doesn't add much. There is typically not significant choroidal involvement. In terms of management, as an ophthalmologist and as a retina specialist, really laser is the mainstay of our treatment. There are many modalities that have been used, and when the tumors are very large, the management becomes much more complex. But ultimately, all of our management centers around destructive therapy, and laser is the most effective at that. The best absorption comes from green laser. Red is not absorbed, yellow is marginally effective. So we tend to use green laser. And depending on the size of the tumor, you may have to whittle away at it. So a small lesion like this is easily treated with a single session. And you'll see involution of it. If it's a fibrosed lesion, it will remain. You'll see there's still the white nub pictured over here. And so it may not go completely flat or disappear, but you repeat a fluorescein. If it's a late stain, you know it's just the fibrosis, but if it lights up early, then you may have more laser work to do. This is a case of a guy who came to me when he was 19. And these peripheral lesions are tough because we know, especially when they're this large, we know that they will fibrose and pull further. And so that complicates the clinical course overall. Nevertheless, I don't like to go into an eye surgically that is this active. And we'll start by treating with laser and try to carry these patients along, but know and warn them that if they contract and fibrose, as he did, that we may wind up inside the eye. So ultimately, this guy received multiple laser sessions. You can see an encircling band. He underwent vitrectomy, oil tamponade, but we were able to preserve his vision. To get this tumor to die down, I had to laser it nearly a dozen times. And so it is, and that was several sessions pre-OR, and then we go over it, we go over it in the OR, and ultimately we needed to extinguish the perfusion of this tumor. If you don't, it will keep smoldering and fibrose further, and you wind up losing the eye and losing the sight on that side. So pre and post, it's, to me, very interesting to see the change in those feeding and draining vessels. His tumor had co-opted both arcades, and they returned to nearly normal architecture once we've dialed down the angiogenic drive that comes from the tumor itself. Now, anti-VEGF agents have had a good look, and for exudative detachment that's involving the fovea, I do find it very useful to recruit the patient and get a little buy-in on their care, but we all know that they wear off. And so I have not found much success in having them modify the behavior of the tumor long-term, other than controlling exudation. So it's really a short-term tool for vision recovery. Using it as a long-term tool will take significant commitment. And this is a case of a kid who's known now to most, well, all of our VR fellows and most of the residents who have come through. At the age of 9, he presented with a pheo, and unfortunately was found to have this epipapillary hemangioblastoma. And these are really the worst of the cases that you'll have to deal with. Typically, their prognosis is abysmal. Historically, most of these patients lose all sight in the eye, if not the eye itself. And obviously, our treatment options are limited. The most effective treatment, hot laser, is off the table unless we're really in a bind. And what we need to avoid is this. This was another patient whose juxtapapillary tumor had been observed, and it had been slowed down with very light laser, some PDT treatments, but you can see that useful vision in this eye is negligible. And here we are. So anti-VEGF agents serially on this really had not solved the problem. For this young guy, I started with PDT. We started with the least bad thing and found PDT to be terribly ineffective. He began to exude. We started with Avastin. This is a trip to the OR every 8 weeks for the last 10 years for this kid. Thankfully, he now can handle injections awake. He is VEGF responsive, anti-VEGF responsive, but the problem was duration. And so really we've targeted exudation to try to keep it out of his central fovea and keep him at the 20/25 level. Ultimately, I've switched him over to aflibercept and maintained him on aflibercept for the last half a dozen years. And I actually just saw him last month, and he is now doing very well. He's now 10 years out. At one point, the exudation started to push through what the anti-VEGF could handle. We gave him low-dose fractionated radiation to the optic nerve head, which just dialed things back enough to be able to manage him with ongoing anti-VEGF. He's about to go to college, and now we have to figure out, will he be a responsible college student who goes in every 8 weeks for his intraocular injections or not? This next case is one that highlights multimodal therapy, and the tumor itself, in terms of size, does not really present an issue, but its proximity to the optic nerve and the macula do. And she had had this tumor. It had been watched for several years. But the exudation had begun to involve the central macula. And what we needed to be able to do was not provoke worsening of her central vision. So you can see on angiography, it lights up. And in fact, this tumor had grown into the subretinal space, making it just a little harder to get to. So she started 2050, treated her with light laser and Avastin. The vision dipped. And you have to stick with these patients and this family. You will get to know them very, very well as you work with them over time. But ultimately, with anti-VEGF, I was able to get the exudation to dial down enough to be able to laser the tumor, the goal being to apply laser with the least amount of tissue destruction needed. And so if we can have that, the hyperpermeability of the tumor decreased by the anti-VEGF injections, typically it requires less laser. Ultimately, we got her back to 2030, and you can see what this tumor looked like partway through her treatment course. You see the laser around the lesion. This is in detached retina, so it makes it very hard to target. But as we got the retina to settle down, then it allowed me to apply a little more energy to the subretinal tumor. And ultimately, we had to persevere until we're able to get this pinkish hued tumor under the retina to fully settle down. And now she's been inactive and she's off treatment and fully resolved. This video is not narrated off of the web. This is my case. And so these are fun cases. Even though you've seen one of these, I'll let this one spool as well. Fun if you're the surgeon, less fun if you're the patient. This actually was a guy who had a spontaneous hemangioblastomas. So he did not have VHL, but he did have the tumor, and that does occur. I like to thread the suture without a needle on it. So just reach under with subretinal forceps and pass it. You know you're making a retinal break anyway. And once you get that tumor out and tie it off, you see massive change in the draining and the feeding vessels. And so this guy had poor vision to start. So, unfortunately, his macular scar persists, but we were able to control the disease. He actually presented with rubiosis. And so he's teetering on the edge of globe loss, and instead he's moved on down the road and is doing very well many years later. Bill's already reviewed a number of the other treatment modalities, and so I will only briefly touch upon these. Certainly there's precedent for surgical excision, and as noted in his literature and some of these papers, these patients can do reasonably well. Really, I explain it as primary goal being globe preservation, and we do see some visual improvement. These tumors, as in the juxtapapillary case that I showed, they are radiosensitive, and depending upon the location, they can be plaqued if they're peripheral. I think it's probably easier and a little less resource intensive to treat them just surgically, either with laser or vitrectomy, but they are radio responsive. For the juxtapapillary and the epipapillary tumors, radiotherapy historically has actually been one of the main management modalities, certainly in the pre-VEGF era. The last look back that we did amongst our cohort of patients here at CU, which now has climbed to about 40, but this was from about a year ago. We had 31 patients, 15 only of them had the mutation, and 24 out of the 31 had clinical findings in the eye systemically of VHL. So 2/3 had a retinal capillary hemangioblastoma. And in only one case were we the ones who were precipitating the workup and leading to diagnosis. But you can see there's pretty even distribution between right and left sides. And half of them had bilateral disease. 40% of these patients in follow-up have had new tumors arise. And so each one of those presents an opportunity to extinguish the disease very early on. Lasering one of these when it's a brand new tumor that's less than a disc diameter in size is something that every person in this room could do with a very low risk of complication. Most importantly, we've sought to preclude progression of bilateral blindness, and in none of our new patients has any patient gone on to get worse. This is the pre and post logMOR visual results. So a slope of 1 means they wind up the same as they started. And you can see in general, patients are responding well to treatment and winding up better off. So what about emerging therapies? This has really been a struggle. I mean, everything I've talked about up to this point really hasn't changed in the last 15 years because the underlying mechanism of the disease has not been addressed. Now, there were some early attempts using repurposed propranolol, which does decrease exudation, but it doesn't close the tumor. Sutent also is a systemic anti-VEGF agent. It's used for renal cell carcinoma. So these early cases were patients who were being treated for their renal cell, which, as Bill mentioned, is the primary cause of death in these patients. And the exudation did diminish, but once again, it was not fully closed off. So a number of target agents have some impact on the HIF pathway and have had limited effect, but it wasn't until Merck released this agent first in 2020 and ultimately got FDA approval for belzutifan, which is now FDA approved for the management of patients with von Hippel-Lindau syndrome. And this has changed the entire conversation in this disease. I will be very interested to see if we have patients progressing to severe complications that I've shown you so far. It may be just those who escaped, high quality care at a tertiary center. But hopefully we have fewer and fewer of these very complex cases to manage. So the primary outcome that was studied in the FDA approval trial for Welireg was renal cell carcinoma. And it's a relatively small study, but there was a significant, very significant results in those patients, and it was sufficient for approval. You can see that their kidney cancers got smaller, their CNS lesions got smaller, their pancreatic lesions got smaller. I have had the first few patients starting on this therapy, but we have not actually been able to have enough of them to see what happens to their eye tumors, although we presume that the eye tumor will respond exactly as the CNS tumor does as well. One of the challenges with belzutifan is that it has significant anti-VEGF downstream effects, and so it's pregnancy category X. There's also a concern about it causing infertility. So there's a high degree of hesitancy, especially in younger patients, to starting this. So the first round of patients who are beginning this therapy are those who have advanced CNS and renal tumors and are beyond childbearing age. And we'll try to learn from them about how this will impact our management of the ocular disease. In terms of questions that still exist in the management of von Hippel-Lindau syndrome, to me, one of them is, when do we treat small tumors? So we now can identify tumors. It's pretty easy to find the tumors. Does every single tumor need to be treated? Now, I've taken care of many patients who have had poor outcomes because of a lesion that was observed too long. But it is a little bit of a drag for these patients when they come in and we find one new tumor and we have to do laser, and they come back the next year and find another tumor, and they have to do laser. And they do ask the question, will I be getting laser every single time that I come to see you? And we know that we can observe these in their early phase, but the exact threshold size to warrant treatment still is unknown. Generally, I try to err on the side of shutting it down, certainly by the time any exudation begins. So if there's any amount of subretinal fluid or any lipid that's around the lesion, to me, that absolutely warrants treatment. If an untreated tumor remains in the eye, does that stimulate growth of other tumors? And we presume that it probably does. We know that cytokines are released from the tumor as well. And I think that may be how we wind up with a case like Bill showed, or several of those that I've had, where you wind up with multifocal lesions that may have been stimulated by one of the primary lesions. Should we declare blindness from von Hippel-Lindau? Avoidable. And I think the answer to that question is yes. I think it requires a team effort and careful surveillance, but I actually think that we can achieve that outcome in nearly all cases. And then finally, is destructive therapy really our primary modality for managing this? Or in fact, will we be taking most of these patients, putting them on belzutifan, and then we're just reporting results to the rest of the VHL team? And I think that question is unanswered, and it will take many years to be able to really find a long-term result on that. So to summarize, the detection part is fairly easy. Photodynamic therapy is marginally helpful. Anti-VEGF plays a limited role, but it's not primary therapy. Definitive destructive therapy with either radiation or laser is really the mainstay, particularly for advanced lesions. If you do treat these, treat them until they're completely closed. So a homeopathic dose of laser, because you haven't done focal laser in a long time, doesn't do it. Keep lasering until you've closed the vascular channels, and then work with a multidisciplinary team to make sure that these patients are plugged in. The final thing that I want to make sure everyone's aware of is the von Hippel-Lindau Alliance. This is a patient-driven network. They've integrated very nicely with the clinical care centers and have come up with designations of comprehensive care centers that are located around the United States. This exists as a resource for patients. And the first conversation that I have when making this diagnosis or explaining this disease to patients is to make sure they're connected on VHL. And that serves several roles. The patient networking part is very, very helpful. This disease is rare enough that people tend to feel very isolated and not know anyone else who has this disease. And if you're a teenager who's having multiple procedures in multiple organ systems, it's really a drag. And it's nice to be able to meet a few other kids who are putting up with it along the way. Certainly for parents, it's a huge relief to meet other families that are trying to manage this disease. And the overall goal of the VHL Alliance designation for these care centers is to make sure that each center has identified specialists that are versed in management of the endolymphatic sac tumors, the CNS tumors, the renal tumors, the pancreatic lesions, the eye lesions, so that they're not having that fractured care that was outlined in the first case. So this is our landing page on their website. We hosted in 2018 their annual meeting here. There's a scientific component to the meeting as well as a patient component to the meeting. And so please make sure that your patients are aware that this resource exists for them. So with that, I'll close and certainly invite any questions. Thanks everyone for being here, and good luck to all the applicants. Questions or comments? Great. Yeah.
It's a little bit related to the unanswered questions, but I wanted to hear your opinion. What is your mindset for those isolated macular lesions where you know that our treatment options will decrease vision more than the lesion itself? When do you decide to switch from observation to active treatment in this type of patients?
You know, I think there are two aspects to the behavior of the lesion that will impact things negatively down the road. one of them being the size of the tumor and the other being the exudation or downstream fibrosis that comes from that tumor. Being able to stop tumor growth, to me, is the primary goal. As I showed in the case with the kid who had the tumor on his optic nerve, that lesion has not enlarged in a decade. And we've achieved that with targeted VEGF suppression. So ideally, we eliminate the tumor, but if you can't, then I think if you can keep it from getting any larger and try to control the exudation, we call that good enough, but also make sure that they understand the need for pretty intense follow-up. And there has to be a good relationship with the patient, a good mechanism to take care of them serially. You have any thoughts on it yourself, Andres? You have any thoughts on it yourself?
I think it's difficult, you know, like for peripheral lesions, it's easy. Like the decision to treat is pretty straightforward. You know that you could observe them, but many of them will cause complications over time, as you just showed. So I'm not an expert as you are, but I think observation can be a great option for some of these patients with macular lesions. But taking that decision or counseling the patients when to treat, I think it's a challenge in itself. I don't know.
Yep. Great. Well, everyone, have a great visit and a good day. Take care.